Hello, everyone, and welcome back to the Clinical Team podcast. Today we have Craig Wilkins with us talking about the new ventilation guideline. Craig, do you want to quickly introduce yourself?
Yeah, thanks for having me. I'm Craig. I'm the Specialist Lead for Enhanced and Critical Care.
Perfect, thank you so much. And of course, as always, we've got Chloe and Caroline here as well. Hello, both of you.
Hi. Hello, how is it?
So thank you so much, Craig, for joining us today to talk about the ventilation guideline. It would be amazing if you could give us a little bit of a rundown of the new guideline and the reason why it's coming.
Totally. So it's really interesting when we look at JR Calc previously, if you put the word ventilation in, nothing came up. It was almost not acknowledged that a patient sometimes required ventilation, apart from the classic, if it's under 10 or over 30, do something, but no one was really sure what that something was. As a trust, we had a guideline on end tidal when that was introduced a number of years ago, but we're probably all fairly familiar with it, and we've not reviewed it since to see how we can link those two things together. And I think the old guideline was good at telling us what an end tidal is, and this hopefully is looking at how we link the end tidal a bit more to what the body's doing to understand it a bit better.
So we talked previously on another podcast, Craig, about the airway guidance that you'd written. Why is this not sort of lumped in together with that? Isn't it all sort of the same?
Yeah, it's a really good point, and I struggle where the line goes. And I'm a simple person, so I always go back to primary school. My head bone's connected to my neck bone. My neck bone's connected to something else. I think it said in the song. And as a result, where do you stop? The body is all connected. And I think previously, certainly I've been taught airway and breathing, and then circulation is the next bit. And actually, I think that's where some confusions come in with end tidal, because end tidal, although we read it through the airway and it shows us the sign of their ventilatory status, it also gives us a real insight to the patient's circulatory status. And I think that disconnect in the way that we thought of it previously can be a bit confusing. So by trying to make it completely separate, airway, breathing, circulation, we can identify how unique each aspect is, but how they are completely interlinked because they're all coming from that same body.
Great, thank you. So in that case, could we talk a little bit about end tidal and cardiac arrest, how we should maintain it, the numbers that we should be aiming for, things like that?
Yeah, brilliant. I think this is one that's caused people real confusion. And that's probably because there's not been a huge amount of guidance about it in the past. The first thing to decide is whether you've got a well-seated airway. So if you've got a well-seated airway, you can afford to ventilate for your adult once every 6 seconds. If you haven't, then you want to go to your standard 30 to 2, 15 to 2 methodology. The reason being that what we used to see, and what I've seen quite often actually, is when you go out, is people ventilating at different rates in cardiac arrest. The reason we want to keep the ventilation rate the same in cardiac arrest is because ventilation then tells us other things. So that end tidal number on its own is a bit useless. What we're looking for is a trend. So if you're keeping the rate at the same, then the change must mean it's something to do with the circulatory status primarily. So if it starts to go down, we know that might be due to CPR fatigue, or it might be due to a blockage in the airway or breathing system. If it starts to go up, we know that's an improvement in CPR or the potential for a ROSC. But if you start to change the rate, then you're going to change the number as well. So by keeping the rate the same, you can see what's going on underneath with that patient's circulation.
That's a really helpful way to think of it, like keep that's almost your baseline and make sure everything else is kept around that.
Yeah, absolutely. And I think we're quite proud as paramedics and ambulance people. We're taught, that it's you and your crewmate against the world. And actually, if we have to do CPR for 2 minutes before we swap over, if we can see that the end tidal is going down during that 2 minutes, then we should swap over earlier. Particularly people with larger body habitus, or if we've just been doing CPR for a while waiting for our backup crew, we're going to get fatigued. So it might be really sensible to swap every minute to provide good quality CPR to maintain that end tidal as much as possible. If the end tidal is dropping off and the waveform's reducing, so when we think about waveforms in a moment, then we need to start thinking about, is that airway clear? Is that carbon dioxide still getting out to the point at which it's being measured?
I'm glad you touched on waveform there, actually. Can we talk a little bit about waveform? I guess, you cover in the new guidance the different sort of waveform. I said that a few times in that sentence, didn't I? Waveforms you might see, and what if you have none?
It's a really good point. So let's talk about what end tidal waveform is first of all. So we're looking at the end point of respiration. That's the number that comes. The waveform's the really interesting bit because it can tell us how well that patient is ventilating. What we've done is we've simplified things down to 3 classic waveforms. So the first one's what we describe as that top hat, which is the standard breathing out. There's a sharp rise to a peak, and then it drops off as the patient breathes in. That's what we'd expect to see with everyone who's breathing normally and everyone that we're ventilating. The second is what we call more of a sharp fin type, where it takes a longer time with a strange curve to get the most end tidal coming out. And that's because something's blocking that airway. Now, that could be that there's a foreign body in the airway. That could be that the I-gel's not seating very well. It could also be something intrinsic to the patient. So it could be COPD or asthma, causes that obstructive respiration type pattern. The third one that we've included is what we'd class as a cleft. Whereas if you're ventilating a patient, it should have a standard top hat. If there's a dink in that top hat at any part, that means the patient's trying to breathe against you. And that's a sign that that patient's trying to start to do something for themselves, which is great. We need to recognise that and support them with it.
I guess, what about if we don't see anything at all, or what if we see something that's not covered in that guideline, anything you've just spoken about?
Yeah, brilliant point. If we don't see anything, so if we don't see one of those 3 that I've just described, the best thing to do is to phone the Emergency Trauma Resource Advice line. Now, that is if there's something going on. So if there's something happening on the screen with the end tidal, but it doesn't look like you'd expect, phone someone else to talk it through. And we can always Good Sam you or to describe it and work out what's going on and if we need to change what you're doing. But those 3 are likely the things you're going to see. So anything else is so rare, it's probably not worth committing to your memory. If I'm honest, because we've got so much to think about and so much to fit in our heads. Actually, I wouldn't stress about anything else. Phone someone else and it's their problem to worry about that. In terms of no end tidal, that is a problem. People often say, oh, the machine will show me no end tidal. Well, was it the machine or was the patient not giving you an end tidal? So we know that end tidal shows us 2 key things. It shows us that air is coming from the lungs out to the machine where it's being measured. And in order for that air that moves out to have an end tidal reading, there must be cellular metabolism happening in the body and the circulation moving it back to the lungs. So we know that those 2 things have to be happening. So if we don't have an end tidal, one of those 2 things isn't happening. And normally for us, it's going to be the fact that the patient's airway has a problem. So if the patient's in cardiac arrest and we're not doing CPR, then even if we bag them when we're not doing CPR, you're probably still going to get an end tidal if we've got a clear airway. There's been studies on corpses, in fact, 24 hours in a fridge. If you intubate them and ventilate them, you get an end tidal. So an end tidal number on its own does not tell us that this patient is alive. It's not a useful parameter as a solo marker, but it does give us a good trend. If you're looking at your screen and you've got 0 and you've got no waveform, then we need to think something's blocking the air coming out. And at that point, we need to think back to our airway guidance and think what is the most appropriate airway for this patient. So in this guideline, there's a little flow chart, and I think we're going to put it in the Zolves as well to make it really nice and simple for people. So that if you've got no end tidal and you can't ventilate the patient, i.e. you can't see chest rise and fall, and you can't hear air entry, then what we need to think about is changing the patient's airway. We need to reposition it. We might need to change the I-jar size. We might need to try a 2-person bagging technique. We might change a bit of OPA or an MPA. We remember from the airway podcast, we've burnt the airway ladder. It doesn't exist anymore. The best airway is the one that works for that patient at that time. So wiggle it about a bit and see what works, which sounds very technical, doesn't it? But effectively, that's what any of our anaesthetics colleagues would do. If it doesn't work, tilt it a little bit and find that sweet spot that works for that patient. More plastic doesn't necessarily mean better. If, however, you've been ventilating this patient quite happily and the bag's been relieving, the chest has been rising and falling, and you've been auscultating the chest and you've had good rise and fall, and all of a sudden it goes to 0, then it could well be a machine thing. So if you're confident when you look at that patient, the patient is still ventilating, you can see the chest rise and fall, you can hear the air, but you've got nothing on the monitor, then the flow chart takes you through a couple of problem solving things with the equipment. And it normally means that it's been kinked, so the little tube has been kinked, or the machine is recalibrating itself. It's more often than not an airway problem. And I think what we have to say is if you've got no end tidal, the patient's not ventilating. That's where we should set ourselves up first of all. The best case is it's a machine problem. 9 times out of 10, it's a patient problem. We need to fix that.
I like that on the flowchart as well. It says work backwards from the patient to the monitor. It's quite a good way to put it. But don't do what I do and just forget to turn it on the monitor.
Yeah, absolutely. So that's a really good point, and thanks for being so open about it. There's one word in bold in this clinical guideline. I don't particularly like bold, but it's the word must. So any patient who's having any ventilatory support must have end-tidal. Now that is as simple as a BVM. That is as much as an IGEL in a cardiac arrest. As if we're augmenting someone's breathing, that's significant, and I think we underestimate how significant that is. Think back to our theatre placements. We were so lucky if we were able to touch the bag, if we were able to get near the patient's mouth, because the anaesthetist spent 12 years to squeeze the bag. If we think to our ambulance staff, what tends to happen is we throw the bag at someone and then they squeeze it, and then we give them loads of other jobs to do as well. Move to theatres, move to a trauma centre, that one person who's looking after the airway is there, and they're looking after the airway and they're looking after the breathing. We learnt at day one of ambulance school, air goes in and out and blood goes round and round. And as long as those two things are happening, then we're all right. And what we tend to do sometimes is we kind of forget about how significant ventilation is, which is weird, isn't it, when it's the first lesson we're taught. And as a result, we should really focus on allowing someone the time to be at that airway and on that ventilation and look after it. Because it's so easy to go from 1 every 6 seconds to suddenly 1 every 3 seconds to 1 every 2 seconds. Now, if we want to get really technical about it, not only is that changing their ventilatory status, it means that they're probably not exhaling properly because of their I/E ratio. It also completely throws out their acid-base balance. And if we think about acid-base balance, that also causes vasodilation or vasoconstriction, depending on which way we've caused it to go. So we're getting a bit complicated now. And if you're really into it, then go away and read it. But we don't need to worry about that too much if we're keeping everything as standard. But to keep something as standard, we need to afford someone the time to do it properly.
You mentioned right at the beginning a couple of the numbers that we should be looking for when we're using end-tidal. Could you touch a little bit deeper on those and how that changes when we're either not in cardiac arrest, and post-cardiac arrest as well?
Brilliant. So if a patient is spontaneously breathing, their end-tidal is whatever their end-tidal is going to be. All right. So if they're breathing and chatting, let's think about our hyperventilating patient or a patient who's tachypneic for whatever reason. JR Calc used to say if their rest rate's over 30, bag them down. But if anyone's had a go at that, it doesn't work. All right? It just isn't a thing. What you do is you cause significant amounts of PEEP, significant amounts of stress and pressure by forcing a bag onto someone's face. What we need to think about is why is that person breathing so quickly? What's the underlying cause and how do we fix that? So if it's asthma, we need to give them some drugs. If it's hyperventilation, we need to give them some support. Psychologically potentially, and talk them through that thing. We need to look at the underlying thing as opposed to just focusing on a number that's not going to tell us an awful lot. The end-tidal needs to be taken in consideration with the respiratory rate. If at the other end of the spectrum we've got someone who's hypoventilating, so they're breathing at, let's say, 4 a minute, then we need to augment that. We need to focus on their oxygenation by ventilating them, and we need to try and get their end-tidal to be in the normal realm. Now, we're saying normal, and normal is a big debate for anyone, but normal for end-tidal we're saying is 4 to 4.5. The reason for that lower end of what we'd consider normal generally is because we know that the transition from end-tidal reading to arterial blood gas is normally about 1 kilopascal out. So if we can aim for a slightly lower end of normal at end-tidal reading, hopefully the blood gas is going to look a little bit better. When we come to cardiac arrest then, as we said, in cardiac arrest, we're just going to go for that once every 6 seconds, or the 15 to 230, to depend on our age of the patient. When we get that ROSC, which is what we're hoping for, isn't it? Then we want to think about how we change that ventilation to stay within that 4 to 4.5 bracket. The first thing to say is that it doesn't happen overnight. It doesn't happen quickly in that respect. So I think sometimes we can get a ROSC and the patient's got an end-tidal of 8. And we go, right, we need to get them down to 4, and we'll bag them really, really quickly. And it's too much for the body to take. As I said earlier, we're not just squeezing a bag, we're changing their entire acid-base balance. It's a huge shift to someone who's already been through a massive physical insult. In some studies in hospital, it's taken 4 hours to take a patient to go from an end-tidal of 5 to an end-tidal of 4. And we expect ourselves to do it in the back of a van in 20 minutes on the way to hospital. It's not fair to the patient. It's too much for them to take. And as a result, we destabilize them. So what we want to do is work towards a trend. We want to work our way towards a number. So if we have a patient whose end tidal is low, then we want to slow our ventilation status down. So if the end tidal is less than 4, we want to breathe for them, we're saying once every 9 seconds. So go from that standard once every 6 to once every 9 seconds. And that just allows the carbon dioxide to build up ever so slightly, that acid-base balance to change ever so slightly, and over time move them towards the 4 to 4.5. If the patient's end tidal is over 4.5, our suggestion is to ventilate once every 3 seconds and try and move them down once again slowly towards that 4 to 4.5. If you don't get there, that's fine, because actually in hospital, they might not get there for some time, as we said earlier. You know, A&E will try, ITU will try, and it'll take some time. We've gone with 3, 6, and 9 because they're really nice, simple numbers. You might see our critical care colleagues do some random stuff, particularly with head injury patients. And that's fine, because there's lots of underlying pathology they're thinking about and lots of drugs they're going to use to counteract the impact they're having through ventilation. But as a general rule of thumb, if it's low, go slow. If it's high, let it fly. So 3 seconds if it's low, 6 seconds if it's in that range that we want, that 4 to 4.5, and 9 seconds if it's a little bit high.
Nice, easy maths, 3 above or 3 below. I like that.
Nice.
So I guess if we were sort of saying to people, this is a really quick breakdown of this new guidelines, what are the real important take homes you want people to remember from these guidelines, Craig?
Lush. So I would like, as soon as we're doing anything for the ventilation of this patient, stick an end tidal on. I would like us to remember that if we've got no end tidal, we've got no ventilation. Fix the problem and work backwards from the patient. You know, don't treat the machine, treat the patient. That's always our mantra, isn't it? I'd like us to remember that in cardiac arrest, once every 6 seconds, that's all we've got to do. Baggy bag, bag, bag. Once every 6 seconds, probably a bit quicker than once every 6 seconds with another. And then think about that standard number. 4 to 4.5 is what we're aiming for. End tidal ventilation is a gentle thing. So it's a significant science, but also a beautiful art. One thing that we can all be guilty of, particularly when we're adrenalized, when we're treating really poorly patients, is squeeze that bag a bit much. And if we think about the barotrauma that causes by doing it too hard, and the volutrauma by doing it too much, that's significant to the physiology of those patients' lungs and their onward care journey. We just want to ventilate them just enough to see the chest rise and fall. So I want it nice and gentle, a real caress of the BVM, if you will, just to see that chest rise and fall beautifully. And to do that, stick someone on the airway and stay them there.
And it is worth having a look, isn't it? It was a good flowchart on there, and remembering there is help there if you are having trouble, I guess.
Absolutely, yeah. There's always someone at the end of the phone. This is not something that we see terribly often on the road, is it? You know, having to manage someone's ventilation. We know that 80%, 90% of our patients are urgent care patients, and as a result, that's where a lot of our learning and training goes, and a lot of our mind is filled up with that sort of stuff. But no one else is coming out to help us with these patients. You know, you can't phone the out-of-hours GP to give you a hand. The district nurse is certainly not going to come out. Mental health nurse is not going to come out and give you a hand with a BVM. So as a result, it is us. But this is our world. It's unfair to expect us to remember everything, and that's why we've got specialists at the end of the phone. So don't be afraid to give them a call, and even if you are pretty sure you know what you're doing, just to chat it out. It's a really sensible thing, and certainly our critical care colleagues do it all the time.
Perfect. Thank you so much for all of the information, Craig. Are there any last bits that you'd like to let crews know about, or do you think we've rounded it off for today?
I think we've rounded it off, but if anyone's got any questions or thoughts, or they think I'm completely balmy and we've gone the wrong way with this, then email criticalcare@swast, and we can go through it, because it's all about learning and developing. And in 5 years' time, whoever takes over from me will say, "Goodness me, what on earth was Craig doing?" Because there's new evidence to light. You know, that's the joy of our job, isn't it? It's constantly changing and evolving. So we should be making it better for the next one. So if you think this is a bit rubbish, let me know and we can try and make it better.
Perfect. Thank you so much for chatting with us.
Thank you.
Bye.